Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Javed Iqbal FAROOQI, working as Professor of Medicine, Gastroenterology and Hepatology in Life Care Teaching Hospital, Peshawar. It's a privilege to join you today through the platform of Educast, an organization that is playing a remarkable role in strengthening medical education and professional development for doctors across Afghanistan. I am grateful to Educast for creating this forum for continuous medical education and to Life Care Hospital for its ongoing collaboration and support in building clinical capacity in the region. Today's session focuses on a topic that remains a major public health challenge in our part of the world: the management of chronic hepatitis B and hepatitis C. These infections continue to affect millions, and timely evidence-based management can prevent cirrhosis, liver failure, hepatocellular carcinoma, and premature mortality. As clinicians, our understanding of updated guidelines, practical treatment pathways, and real-world considerations is essential for improving patient outcomes. In today's lecture, we will review the latest diagnostic approaches, staging tools, treatment indications, antiviral therapies, monitoring protocols, and special population considerations, so that you can confidently apply these principles in your daily clinical practice. I look forward to sharing insights, simplifying complex concepts, and discussing practical strategies that can support you in managing these patients effectively. Let's begin. Bismillahirrahmanirrahim. As mentioned in the intro, topic for today's discussion is management of chronic hepatitis B and hepatitis C. Greetings from my institution, Life Care Hospital and Research Institute, Peshawar. The learning objectives for today's lectures are that by the end of this session, you will be able to understand updated guidelines for hepatitis B and hepatitis C, to diagnose and stage chronic hepatitis accurately, to identify treatment indications, to choose the right antiviral regime, and to monitor treatment response and complications. This is hepatitis B virion, and this is hepatitis C virion. When we do the cross section of or cut the hepatitis B virion, what we see, it has got a surface, it has got core, and it has got different antigens. This is the surface antigens, the large surface protein, and this is the medial surface protein, and this is the small surface protein. So the surface antigen has got three types or three proteins: the small protein, then the medium protein, and the large protein. So it has got a surface antigen, and then it has got an envelope antigen or hepatitis B E antigen, these one, the green one. You see these ones. And inside the surface there's a core, and it has got core antigen. So the hepatitis B virion has three antigens: the surface antigen, which consists of three types of proteins: the large proteins, the medium proteins, and the small proteins, and then the hepatitis B E antigen and the hepatitis B core antigen. So these are the three antigens. Then it has got a DNA polymerase inside the core and the DNA. So the hepatitis B virion has got these two main components, the surface antigen and then the E and the core antigen, and inside that has got the DNA polymerase and DNA. And this is important to understand because what body does, body produces antibodies against these antigens, the anti-HBs against HBs antigen, anti-HBe against HBe antigen, and then the core antibodies in the form of IgM in total against core antigen and of course the DNA. And this is important when we do the profile, we check these antigens and these antibodies and PCR, and we will discuss later on. Now coming to the hepatitis C virion. On the cross section, it has got a lipid envelope, the blue one, and it comprises E1, E2 glycoproteins. Then inside the envelope, it has got capsid, and within the capsid is the single-stranded RNA. You need this one. So this is the cut surface or the cross-sectional of the hepatitis C virion. This is important to understand when we will discuss the management of these infections. Now, what's the difference between these two? Where these two create problem? This is the hepatocyte, cell of a liver. This is the nucleus, and this is the cytoplasm. So the diagram of hepatocyte, and this is the nucleus. These are the smooth endoplasmic reticulum, and this is the nucleus. The hepatitis B virus, when it enters the hepatocytes, the surface antigen is left outside, the core enters, and then it traverses the cytoplasm and enters the nucleus and becomes part of the nucleus. So it enters the nucleus and resides over there. In comparison to hepatitis B, the hepatitis C virus, it remains within the cytoplasm and damages the smooth endoplasmic reticulum. So the hepatitis C virion is the cytopathic. It damages hepatocytes directly, while the hepatitis B, it enters the nucleus, becomes part of it, and when it produces the proteins, these are the antigenic proteins, and the human body self-immunity, it attacks those hepatocytes where the hepatitis B virus is replicating, and thus the hepatitis B virus causes indirect damage to the hepatocytes. And because of hepatitis B virus residing within the nucleus and hepatitis C virus residing within the cytoplasm, we can eradicate hepatitis C with the current available drugs. While we cannot eradicate hepatitis B with the current available drugs, we can only suppress this infection. This is important to understand. Let's move forward. What's the global burden of hepatitis B and hepatitis C? Worldwide, there are 296 million people with chronic hepatitis B, and this leads to 820,000 deaths per year. It's a huge burden. Then the hepatitis C, 58 million people with chronic hepatitis C are there in the world. And hepatitis C is causing 290,000 deaths per year. So it's a huge burden. And when it infects the patient and we don't treat that patient, it leads to a progressive damage to the liver. How is that damage? When the hepatitis B or hepatitis C infects the normal liver, to start with, there is inflammation, but no fibrosis. But we know these leads to chronic hepatitis or chronic inflammatory conditions. And in the chronic inflammation, with the passage of time, there is deposition of fibrosis. So as the inflammation goes on uninterrupted, then the fibrosis starts depositing. So there is initially liver without fibrosis, infected liver without fibrosis, then it's a fibrotic liver. And the level or the degree of fibrosis is initial, which is called F1 fibrosis, intermediate fibrosis F2, and then advanced fibrosis F3. And when it reaches F4, it is called cirrhosis. And then when the liver reaches the cirrhotic stage, then its other complications, they appear. The hepatic encephalopathy, the varicose bleeding, the ascites, the tumor. We will have a separate lecture on this, that how to keep cirrhotic patients alive in the future, inshallah, very soon. But remember, whether the liver has been infected by hepatitis B or hepatitis C, if these infections are not treated, not interrupted, the fibrosis starts depositing and the liver converts from normal liver to fibrotic liver, and this is the increasing severity of fibrosis, and then it becomes cirrhotic liver and develops its complications. So it's very important to remember this whole sequence. And clinically, it's not necessary that you will get patients with, in this early stage, a patient may come to you hepatitis B or hepatitis C related liver cirrhotic. The patient may come to you in the stage of cirrhosis or in the stage of fibrosis, and the fibrosis may be initial, intermediate, or advanced. So depending upon the patient presentation, your clinical judgment and your clinical advice differs. And we will learn in this lecture how we do make our decisions in different clinical scenarios. So regarding the treatment, your patient may be having no fibrosis or just insignificant fibrosis, or you may deal with a patient who has got either fibrotic liver disease or the patient is cirrhosis. So once again, never expect that a patient will come to you in the initial stage and then it will go on. You may get a patient at any stage. Therefore, it is very important to think and to evaluate and to assess what is the stage of the liver status, or what is the stage of fibrosis in my patient, and then you will decide accordingly. So, what should be the treatment protocol? A patient comes to you with hepatitis B or hepatitis C, test positive. How will you proceed? 3 steps. The first step is assessment for treatment eligibility. The second step is for general care measures. And the third step is antiviral treatment starting. And the fourth is monitoring of antiviral treatment. So the treatment protocol for hepatitis B and C has these 4 steps. First step, assessment for treatment eligibility. Second step, general care measures. Third step, initiate antiviral therapy. And fourth step, monitoring of antiviral therapy. No, we will discuss each and every component in some detail, and this slide will remain fixed so you remain on the point that which step or which stage we are discussing. So first, take this assessment for treatment eligibility. So it requires detailed medical history, physical examination, and investigations. With the help of these 3, detailed medical history, physical examination, and investigations, you do the assessment for treatment eligibility, whether my patient is eligible for treatment or not, whether my patient needs treatment or not. Few words about the medical history. Age of the patient is very important. We will discuss this in the coming slides, how the age decides about the treatment. Second, has the patient presented with acute hepatitis? You think whether the patient is jaundiced and has clinical features of acute hepatitis. If not, any past history suggests of acute hepatitis in past, whether the patient was having any history. Then if not, then how was the person found to be HBs antigen or anti-HCV positive? Patient has not presented to you with acute hepatitis. There is no history suggestive of acute hepatitis in past. Then how the patient has come to know that he or she is having B or C positive? It may be just screening, pre-op screening, or pre-blood transfusion screening, or job screening. In the medical history, again, you ask about the any history suggestive of liver cirrhosis at present or in past, whether the patient has presented you with hepatic encephalopathy or bleeding or ascites, or is there any history suggestive of hepatic encephalopathy or any history of upper GI bleed or any history of ascites. It tells you that what is the stage of liver disease. Then, of course, any co-infections, comorbidities, because hepatitis B, hepatitis C, and HIV, and hepatitis D, they have got the same way of spread. So you ask if the patient has presented to you with hepatitis B. You do ask whether the patient has got hepatitis C or HIV or not. And the comorbidities like diabetes and fatty liver disease, these are very important when you decide that which treatment will you give and whether you will treat the patient or not. Then if the patient has family history of liver cancer or cirrhosis, this is again very important. Patients with a family history of liver cancer or cirrhosis, the threshold for starting treatment is low. And of course, immune suppressive therapy or extrahepatic manifestation of hepatitis B, we will discuss in the algorithm to come. So this is very important points of the medical history. Then the physical examination. Again, this is another way to assess the patient for treatment eligibility. In the physical examination, any clinical evidence of ascites or peripheral edema and peripheral stigmata of liver cirrhosis. This is very, very important, and it can tell you if your patient has become cirrhotic or not. Then coming to the third component of assessment for treatment eligibility, this is the investigations. And you do 2 types of investigation to know the liver status, severity of liver disease. And you do this with the help of abdominal ultrasound, a non-invasive test to determine liver fibrosis, and of course the lab workup, the virological test to know the co-infection, and of course the baseline labs. The ultrasound, it tells you whether the patient has got cirrhosis or not. And the non-invasive tests, which you can find out the fibrosis level. This is the small smartphone tests, the APRI and the FIB4 and the elastography Fibroscan if that is available. And this is how it helps you the APRI, the FIB4, which is the smartphone-based calculators where you just do the age and ALT, AST, and platelet counts, and it tells you whether your patient has got insignificant fibrosis, significant fibrosis, or cirrhosis. And you don't need doing liver biopsy in these patients nowadays. Now these non-invasive tests and the Fibroscan, it tells you that whether the patient has got fibrosis or not, cirrhosis or not. In our center, the Fibroscan facilities are available, and we uh, confirm and say whether our patient is having cirrhosis or fibrosis or normal. Then the second component is that of the lab work, which means virological tests to know the co-infections and baseline. And for the virological test, we do, in case of hepatitis B, we do the PCR, E antigen, and anti-HBV by ELISA. And for hepatitis C, we do qualitative PCR. For hepatitis B, you need quantitative PCR, and for hepatitis C, qualitative PCR is sufficient. To know the co-infection, of course, anti-HDV, anti-HIV, and if they are positive, we'll check these PCRs. The baseline labs are very important, which include serum bilirubin, ALT, AST, serum alkaline phosphatase, CBC, blood sugar, and serum creatinine. And of course, the alpha fetoprotein and PIVKA2 if the patient has got liver cirrhosis, or if your patient is not cirrhotic, but it is male and age is more than 40 and female and age is more than 50. Now, the second component of the treatment protocol is general care measures. Counseling of the lifestyle is very important. Diet and physical activity, no parees is required, and normal physical activity is advised. Alcohol consumption, if someone is alcoholic, he or she should stop the alcohol. Then preparation for starting treatment, which means we ask the patient to be adherent to the treatment, and of course risk factors for renal dysfunction and baseline renal function as indicated, especially in the treatment for hepatitis B. And preventive measures, the BC screening of the family and household members and sexual contacts with HBV vaccination for those negative and HBs negative, and for HCV positive spouse or family member, all his or her family members should be vaccinated against hepatitis B as well. Then to initiate antiviral treatment for hepatitis B, the drugs available are tenofovir, disoproxil fumarate, TDF, tenofovir, alafenamide, or entecavir. And for hepatitis C, the SOF and velpatasvir is available. SOF, DECLA is available, and with or without ribavirin, it may be required. Monitoring for antiviral treatment means for hepatitis B, ALT every 3 to 6 months, hepatitis B DNA every 6 to 12 months, ultrasound every 6 months. And for hepatitis C, PCR is checked at the start of the treatment, then after the end of the treatment, and 12 weeks after the stopping of the treatment, and you check ultrasound every 6 to 12 months. The HCC screening is advised in all those patients who are cirrhotics and you have treated them, because there is still a risk of HCC. And in non-cirrhotics, if male and there's the age is more than 40 years, and in females, age is more than 50 years. And if there is family history of liver cancer, then in those you do the HCC screening on regular intervals. So, my dear colleagues, this lecture will be available on my YouTube channel, The Medicine Made Easy by Professor Javed Iqbal FAROOQI. You can search this channel and you subscribe this, and then there's a playlist, and there are more than 500 lectures on different aspects of gastroenterology, hepatology, and medicine. And you can just go that, and with all those lectures with narration are available, and you can see these. This lecture will also be uploaded to my YouTube channel, and you can watch this lecture on my YouTube channel, and even download for your own library. So we start from the hepatitis B, the management. Remember, hepatitis B is a lifelong disease. Once hepatitis B, always hepatitis B, lifelong hepatitis B. This is when a patient gets infected. The patient may present with acute hepatitis B, and within 6 months, it is so-called recovered HBs antigen becomes negative, and PCR becomes negative, but remember this is called functional cure. At times, the patient may not present as acute hepatitis B. It may present as chronic hepatitis B, and the patient may be present with acute hepatitis B, and after 6 months, the HBs antigen is still positive, and then this is a chronic hepatitis B stage. And in the recovery, what this patient does is HBs antigen remains uh, positive, but the PCR becomes negative. So this is a partial cure where the HBs PCR is negative, but HBs antigen is positive, and this happens in the chronic hepatitis Z, and this happens mostly with the help of the drugs. In acute hepatitis B, there is self recovery, the HBs antigen and PCR both becomes negative spontaneously within 6 months. So acute hepatitis B resolution, and this is called functional cure, not complete cure. While the chronic hepatitis B, it needs treatment, and when you treat that, the HBs antigen still remains positive, but the PCR becomes negative, and this is called partial cure. Why I am saying partial cure? Because the cccDNA, the part of the hepatitis B virion, which has become the component of nucleus, it still remains there in the partial cure as well as in the functional cure. The available drugs are not able to clear this cccDNA. The future drugs, yes, hopefully they will clear this cccDNA, and when the HBs antigen becomes negative, the PCR becomes negative, and cccDNA becomes negative, this is called complete cure, and this will be possible only with the future drugs. So, this is the chronic hepatitis B, which really leads to these stages, the fibrotic liver and the cirrhotic liver. And as I told you, one indication in hepatitis B is when a patient is in having no fibrosis or normal liver, you treat these patients, then your patient may be fibrotic or cirrhotic. But remember, there is a third indication for treatment as well, and this is this stage. Anytime the patient in functional cure may become HBs antigen positive and can become reactivated. And this is another indication to prevent the reactivation. We will know in the algorithm to come where to treat this patient. So there's a third indication, prevention of the reactivation. For hepatitis B, 3 indications: prevention of the reactivation and treatment of the active infection. So, when to start treatment of HBs antigen positive patient and when to stop? We will start our discussion from when to start treatment. And remember, almost every year for the last 15-20 years, we are getting one or another guidelines from either the EASL, the Europe, the AASLD, America, the APASL, or the WHO. And this is the last 3 years. In 2023, the Chinese guidelines, they were published. In 2024, the WHO guidelines were published, and this year the EASL guidelines were published. And what I'll be sharing with you in the algorithm, it's based on the practical or clinical points of these 3 guidelines, and it will help you out how you can manage your patient in your everyday clinical practice. So a patient has presented to you with the HBs antigen positive. Now the question is whether you will treat this patient or you will do not treat this patient and you will do the follow-ups. How you will decide, should I treat my patient with HBs antigen positive to treat or not to treat? 3 steps. In the first step, what you do take the history and clinical examination I have shared with you, and you see if there's any evidence of cirrhosis and its complication. You do the ultrasound for the evidence of cirrhosis, portal hypertension, or liver mass, the non-invasive test APRI, FIB4, and Fibroscan, and you decide whether my patient has got insignificant fibrotic liver disease, F0, F1, or fibrotic liver disease, F2, F3, or cirrhotic. Then the PCR, you see whether the patient PCR is detected or undetected. If detected, then viral load, it's more or less than 2000. Remember this 2000, I have written this in red and bold. This is very, very important. Don't forget this 2000 figure. Then the ALT test, ALT upper limit normal, For male is considered 35 and for female it's considered 25. So you see whether my patient's ALT is normal, within a normal limit, or above normal limit. So in the first step, these 4-5 steps are very important, and you do the patient's assessment, and then you do proceed accordingly. So in the second step, on the basis of your evaluation, if your patient has got cirrhosis or HCC, liver cancer, or liver failure, or he is a patient of liver transplant, or if reactivation of HBV infection is warranted, like a patient needs chemotherapy for some other disease, a patient needs immunotherapy, for example, for rheumatoid arthritis, SLE, or if the patient needs targeted therapy. If these two are the scenarios on the basis of your assessment, what you do, any one of these present, either patient is cirrhotic or HCC or liver failure or transplant, or if reactivation of HBV infection is warranted, any one of these two is present, you start the patient on treatment, either tenofovir or entecavir. But if none of these two is present, in the first step you have done this assessment, and in the second step you liver is normal, it's not fibrotic, the patient has not got HCC, there is no liver failure, there is no liver transplant, and there is no need to prevent the reactivation of the hepatitis B. So you go to the third step, and third step is you check the viral load in ALT. If the viral load is more than 2000, I shared with you this figure here, and ALT is more than normal in male, more than 35, in women more than 25, you treat this patient. It is simple. Okay? If your patient viral load is less than, it is not detected, and the ALT may be any level, but the PCR is negative, LT may be 35 or more than 35 in male, and in female 25 or more than 25, but the PCR is not detected, you don't treat this patient, you just do the follow-ups, 6 to 12 monthly follow-ups. Clear? Okay. But things never follow the rules. Never follow the scenarios may be different. There may be intermediate scenarios, the yellow scenarios. And what are those? Viral load may be more than 2000, but the ALT normal. Or the viral load is less than 2000, but the ALT is raised. Or the third possible scenario, viral load is positive but less than 2000 and ALT is normal. So this is in between these two extreme ends, and this is the yellow regions. So what you do here, then you check for the liver status. And these three scenarios are yellow scenarios. If the patient has got significant fibrosis, if the patient was having cirrhosis, we were directly going for treatment. But here there is no cirrhosis and the patient is not following in these two. It is in the yellow zone. So with significant fibrosis or extrahepatic manifestation of hepatitis B infection, or there is co-infection with ecto, hepatitis D, or HCV, or HIV, or which is more, age is more than 30 years, or there is a family history of liver cancer and cirrhosis. So these 1, 2, 3, 4, 5 points. If any one of these is present in this yellow region, yellow zone, you treat this patient. Clear? But if none of these is present and patient is in the yellow region, then you don't treat and you do the follow-ups. Clear? This algorithm is based upon the three latest guidelines: 2023 Chinese, 2024 WHO, and 2025 ESA. Okay, now the second question, when to stop treatment? Remember the traffic lights, the red, yellow, and green. And these three are the parameters which help you whether you will stop the treatment or not. The antiviral treatment, what type of treatment have you given, hepatic fibrosis, and what you will do. If you have given a patient pegylated interferon for hepatitis B, it may be any fibrosis, F0, F1, F2, or F3. you will stop the treatment after 48 weeks. In all cases, whether response is achieved or not achieved, you stop this treatment after 48 weeks. So it's a clear rule. Peg-alate interferon, stop after 48 weeks. What about oral? There's the yellow light. Hepatic fibrosis is F0 or F1, not F2, not F3, not F4. So you may stop. So there is a chance. How we will stop? We'll discuss this later on. But your treatment is oral antivirals, and the patient has got F2, F3, F4 fibrosis and cirrhosis. You cannot stop. You have to continue your treatment. चलते रहो, देते रहो, बस treatment बावर कवे, बंदवे बना, हाँ? Okay, so these are the 3 ways when to stop or when not to stop. Let's explain this in another way. In peg-alate interferon, stop after 48 weeks of therapy. It's called finite therapy. Oral drugs may stop in case of insignificant fibrosis, F0, F1, provided the patient HBs antigen and PCR become negative, and the patient has received antiviral treatment for additional 1 year after that. PCR, the patient has lost PCR, his PCR and HBs antigen has become negative. You give another 1 year of treatment and then you can stop. But if HBs antigen is positive and only PCR has become negative, and your patient is HBe antigen positive to start with, you should give the patient additional 2 years of antiviral therapy, and with persistent negative PCR, then you can stop. But if the patient is HBe antigen negative, the patient needs another 3 years of antiviral therapy and then you can stop. So when both are negative, 1 year additional therapy. When only PCR negative and E antigen positive, 2 years additional therapy. And only PCR negative, E antigen negative, 3 years additional therapy. But you cannot stop antiviral in case of significant fibrosis, F2 and F3. It's a lifelong therapy, and cannot stop in case of F4 fibrosis, cirrhosis. It's a lifelong therapy. Understand? But nowadays, there's another, the AASLD has said that even oral drugs, in case of even the go out of this yellow, all patients do not stop, continue, just like treatment for diabetes and hypertension. So once again, to remind you, you can watch my this lecture on my YouTube channel and download for your reference. Now coming to hepatitis C, the chronic hepatitis C, few basics. It's a RNA virus. It's a curable with 95%, more than 95% cases are curable with directly antiviral agents. There are 6 genotypes, but no, the regimes are simplified and genotype-free regimes are there. The treatment eligibility is treat all patients with detectable HCV RNA. When a patient PCR is positive, treat them unless life expectancy is less than 12 months and there's active decompensated cirrhosis where they need specialist referral. The basic determinants of antiviral treatments are whether your patient is having normal liver or cirrhotic liver. Okay? And then whether the patient is treatment naive or treatment experienced. Whether patient and the treatment experienced may be interferon or interferon soft riba in the past, or soft riba or soft decla or soft well. So your patient may fall treatment naive with normal liver, that is the green, or treatment naive with cirrhosis, the compensated cirrhosis or the decompensated cirrhosis. Or if the patient may be treatment experienced with one of these drugs and it may be normal liver, or it may be cirrhosis and it may be either the compensated cirrhosis or the decompensated cirrhosis. So these are the determinants in which category your patient falls, and you treat that patient accordingly. What are the types of antiviral treatment available with us? So Sofosbuvir plus declatasvir, or they may need ribavirin or not. And the second group is Sofosbuvir and velpatasvir combo drug. These two tablets are given separately, and this is a combination, and the patient may need ribavirin with soft Velpa as well. How? We shall discuss this. Uh, in case of the soft DECLA, when the patient is treatment naive, I mean no treatment has been given before and the patient liver is normal, no cirrhosis, you give soft and DECLA for 12 weeks. Okay? Give soft and DECLA for 12 weeks. But if the patient has got treatment naive and the patient has got cirrhosis, so you give soft DECLA and ribavirin for 24 weeks. Okay, you add ribavirin and you extend the duration. If the patient has got treatment experience but normal liver, you give soft DECLA and riba for 12 weeks. So treatment naive, normal liver, soft DECLA for 12 weeks, and treatment experienced with normal liver, you add ribavirin and give it for 12 weeks. But in case of cirrhosis, treatment naive, you add ribavirin and give for 24 weeks. And if it was treatment experience, you don't use decletus where there's a chances of recurrence. What about the soft well? Patient is treatment naive with normal liver, you give soft well for 12 weeks. And if the patient is treatment experienced, either interferon or other the DECLA, what you give soft well and riba now for 12 weeks. Okay. But if your patient was treatment naive but cirrhotic, you add ribavirin and give it for 12 weeks. Similarly, for treatment experienced, you give Sofil Reba for 12 weeks, or if the patient is intolerant for ribavirin, you give the Sofvel for 24 weeks. This is the way how you treat these patients. Remember drug-drug interactions with soft and Velpetasvir. There's online this app available, interaction checker, and you can put your drugs, what drugs you are giving, what drugs patient is using, and it tells you whether there's drug-drug interaction, there is no drug-drug interaction, or there is a risk. It tells you with the different color coding. All these drugs, for example, patients using the Sofel or Declar, all those, so the acid-reducing agents, alpha blocker, antiarrhythmics, similarly anticoagulants, antiplatelets, all these drugs, they tell you in which category your patient falls and whether you should use these combo drugs or not. Just to simplify the drug-drug interaction, what I will be sharing with you that antacids reduce soft well absorption and should not be used with that. Amiodarone plus soft power, risk of bradycardia, so be careful. Some anticonvulsants reduce DA levels, so be careful. And rifamycin are contraindicated. A reinfection risk for HCV does exist. Reuse of syringes. Once patient is issued SVR, the patient may get reinfected. If the reuse of syringes pattern is there unsafe dental procedures, IV drug abuse, or tattooing, or sexual transmission low but present. So remember that in hepatitis C, treatment does not prevent the patient from the future infections. The patient may get infected again. For hepatitis B, it's a lifelong infection, and once infected, always infected, and that patient needs a lifelong therapy. Co-infections for hepatitis B, D, HCV, HIV, it's very much there. Hepatitis D may be co-infected or superinfection. Treat HCV normally if BC co-infection, but monitor for HBV reactivation. HIV co-infection, coordinate with ART team. And of course, avoid stopping HBV antivirals during HCCDS therapy. This is very, very important. So, the end-stage liver disease patients manage complications, ascites, varicose bleeding, and hepatic encephalopathy. You do the ultrasound every 6 months, even after the treatment of that, or with the treatment, a referral for transplant when indicated. The last slide, case scenarios. HBe antigen positive patient, DNA PCR 35,000, LT more than 2 times. Yes, you start the patient on treatment, the TDF. HCV RNA positive, compensated cirrhosis, you start give the patient soft well for 12 weeks. The pregnant woman, HBV DNA 250,000, you start the patient, she on TDF in the 3rd trimester. So dear colleagues, the summary of key points. HBV treat based on DNA plus LT plus fibrosis. HCV treat all patients with simple 12 weeks DAAs. Monotherapy is effective and safe. and long-term monitoring is essential. Prevent complications with early treatment. This is the key to success. This is the difference between HCV and HBV. The virus family, hepatitis B, is Hep adenovirus. It's a flavidavirus. Genome, DNA, and cccDNA. HCV is RNA virus. Life cycle, their genome integration, expression of HBV X protein, then insertional activation of cellular oncogene cccDNA, while it is exclusively cytoplasmic. I've shown you in the picture. The HBV persists there as a nucleus located cccDNA. The HCV leads to chronic inflammation, oxidative stress, alteration in cellular signaling and metabolism. The HBV lies within the nucleus. It lies HCV in the cytoplasm. The treatment can suppress only hepatitis B. It cannot eradicate, and that's the reason for hepatitis B, the oral therapy is given lifelong, just like diabetes and hypertension. For HCV treatment, the HCV can be eradicated. So thank you very much for being with me. I hope I would try to simplify the concepts of treatment in today's lecture. Thank you very much for your attention and participation. Chronic hepatitis B and hepatitis C remain major yet fully manageable challenges provided we diagnose early, follow evidence-based guidelines, and ensure consistent patient follow-ups. As clinicians, every correct decision we make can prevent cirrhosis, liver failure, and cancer, and can profoundly change the life of a patient and their family. I would like to express my sincere appreciation to Edocast for creating this invaluable CME platform for doctors across Afghanistan, and to Life Care Hospital for its continued collaboration in strengthening healthcare capacity in the region. It is an honor to contribute to this collective effort. I hope today's session has given you practical clarity, updated knowledge, and confidence for managing chronic viral hepatitis in your daily clinical practice. If you have any questions or would like further educational support, I remain available. Once again, thank you for your dedication to patient care and for joining this session. Khuda Hafiz.